This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Welcome back to Audible Bleeding. I'm Jacob Schwartzman. I'm here today with Dr. Peter Lawrence, the senior editor of the Journal of Vascular Surgery. We are excited to bring you our next installment of the JVS Editor's Choice for December. Welcome back to the podcast, Dr. Lawrence.
Thanks, Jacob. It's a pleasure to be back, and we're enjoying this relationship with Audible Bleeding.
I'd just like to remind our listeners that these articles will be available free of charge on the JVS website for the month of December. So let's jump right in. Our first paper is titled Long-Term Survival After Endovascular and Open Repair in Patients with Anatomy Outside Instructions for Criteria for Endovascular Aneurysm Repair by Dr. Charbonneau and colleagues. This is a multi-center retrospective cohort study from 2003 to 2016 at 3 centers in Canada, comparing Ivar versus open surgery in patients with at least one anatomic violation for instructions of use, or IFU. For the Ivar group, violations were defined as at least one anatomic criteria outside parameters set by the manufacturer for that device. And for the open group, there was a standard set of anatomic criteria predetermined by the study investigators. There were 202 subjects in the Ivar group and 224 subjects in the open repair group. Using log-rank testing and Kaplan-Meier curves, the authors found significantly higher overall mortality in the Ivar group. And this remained significant in Cox regression modeling, adjusting for baseline differences in age, gender, and the presence of kidney disease, with a hazard ratio of 0.6 for open versus Ivar. So, Dr. Lawrence, what are some of the most important teaching points from this study?
Well, I think the importance of this study is that it confirms the belief that's been around for a number of years. I think probably first reported by Roy Greenberg, one of the giants from Cleveland Clinic, who was doing some of the first endovascular and also fenestrated and branched endografts. And they reported a similar result, which was that patients outside the IFU required more procedures, had more complications, and did worse. But what's unique about this study is that they actually match patients, all of whom are outside of the IFU, both the endovascular, so EVARs, as well as the open procedure. The difference to me was that the open procedures are more of generic criteria for the IFU and being outside of it. In other words, if you do an open procedure, you really can't say which one of multiple endografts would have been used had you not done it in an open procedure. So it's more of a generic classification of outside the IFU. But the importance of it is that as soon as you go outside of the IFU, you're trading off slightly better early results, shorter hospital stay, maybe a slightly lower mortality, for long-term, a significantly higher likelihood of dying from your aneurysm if you have it done outside the IFU with an Ivar endovascular approach.
So naturally, the surgeons who were performing these procedures knew that they were performing them outside the IFU. Why do you think so many patients were being offered Ivar outside of the IFU, despite potentially even the availability of more complex devices? Are you surprised by these numbers at all?
I'm not surprised, but I think that it just emphasizes the fact that as a specialty, we've shifted toward doing such a high proportion of patients with an endovascular approach. So in Ivar, in many institutions, it's 80% of patients are having Ivars, that when the appropriate patient for an open procedure or inappropriate for Ivar comes up, the surgeons may be less comfortable, but also the patients are saying to the surgeon, I understand the risk, but I'm willing to take the long-term results for having a lower risk of a procedure and not having a surgical procedure. So I think some of it is related to patient decisions, physician decisions, and that's why it happens.
Now, do you think that, because there's a very wide study period for this study from 2003 to 2016, and naturally there's going to be some evolution of the devices that are available from the beginning to the end of that period. Do you think that that's going to impact any similar types of studies similar to this one in the future without considering necessarily the more complex fenestrated devices that are available?
Probably it will, because as you can see, there's a range of criteria based on the type of device. And I think as devices get refined and improved, that the number of patients who qualify for an Ivar endovascular will increase because of modifications in the devices. On the other hand, as Roy Greenberg talked to us, and again, one of the giants in our field who was very creative and innovative. I remember him listening to a talk once when he's pointed out that this is a disease of the aorta. And even if you have a 1 centimeter cuff infrarenally, that in his opinion, over time, that the aorta, it was an aortic disease that didn't stop always at the renal arteries. In fact, it often did not. And so you can anticipate over a lifetime that there's going to be deterioration of parts of the aorta, which look normal at the time of the procedure. So it does not surprise me that different devices have different criteria and getting better. On the other hand, I don't think it addresses the fundamental issues that unless we can stop the change or the growth in the aortic aneurysm, that there continue to be deterioration in the aorta over time, and that's going to always put the EVARs that are right on the margin, just barely inside the IFU, are going to potentially have problems and have either dilatation or have a endo leak or some type of problem the longer the patient lives.
So you've somewhat touched about this already when you mentioned the open surgical patients and physicians' comfort level, but how do you think clinicians should use this paper to guide their practice?
Well, I think that probably one of the most important things is to try to assess, and we're going to talk about it in one of the other papers for lower extremity, but there are risk calculators, and try to assess the life expectancy of the patient that you're doing your aortic aneurysm procedure on. Obviously, if it's very short, it's probably better to just let the natural history of the aneurysm go. But if it's in that intermediate group, then you may want to do Ivar. But the longer that the patient is, you expect to be alive, the more important it is to do an open procedure if you're going to do a procedure. And the other factors, I think, are to know your patient and whether they're likely to come back for follow-up. Most studies of Ivar have shown that for all comers, even within the IFU, that about 20 to 25% require some procedure during their lifetime after the initial one. Often it could be done with an endovascular approach, but that you need to know your patient and the likelihood of them going up and the likelihood of long-term survival to decide on which one of the two. But the longer they're going to live, I think the more important it is, if they're outside the IFU, to do an open procedure.
Thank you for that. Our second paper is titled Risk Prediction of 30-Day Mortality After Lower Extremity Major Amputation by Jalissant and colleagues. Just for our listeners' information, this is the CME paper of the month, and you can find more details about that on the JVS website. This was a retrospective study using the VA Surgical Quality Improvement Program database to create a predictive model of 30-day mortality for patients with CLI undergoing lower extremity amputations, with the goal of improving on existing universal risk calculators, which the authors believe may underestimate risk in these sick patients. Using CPT code, just under 15,000 patients were identified from 2005 to 2015, and two-thirds of these were selected for model building, and the remainder of these patients were used as a validation cohort. 8 total factors, including DNR status, congestive heart failure, age, creatinine, and amputation level, as well as a few others, were incorporated into the final model, and each were assigned a weighted score And the final scores, after totaling up all of the risk factors that the patient has, were stratified as low risk, moderate risk, high risk, and very high risk. The model then performed very well with regards to internal validity, with a model C statistic of 0.74 for both the model building and the validation cohorts. So, Dr. Lawrence, what are your thoughts on this overall paper, and what led you to select it for the editor's choice?
Well, I think we're increasingly seeing risk calculators to help us in both deciding who should and should not undergo procedures, but also what the relative risk to the patient is, which is important when we're benchmarking for quality and outcomes. And I think the authors of this paper point that out. It's both to benchmark, to let an institution know what the likelihood is that a patient would have a complication or death. And it's also to help in advising families and patients, particularly if they're in the very high risk category. And as you know, they broke this into, I believe it was 4 different categories based on their assessment. I think what I was impressed with and why we selected the paper was because the results are different from the risk calculators of the American College of Surgeons, which is often used. And the risks were different, actually. They were higher with this risk calculator than the ACS website. So I think the importance is that that risk calculators help you in advising patients. They help you in deciding whether to go ahead with procedures, but they also help you when you're benchmarking physicians and institutions when you're measuring quality.
Right. And just as an example for our listeners, this paper quotes a 17.5% 30-day mortality for very high-risk patients. And that's patients who score greater than 10 on the risk calculator. So that's definitely something that families should be aware of when they're making such major life-altering decisions. And you sort of mentioned this already, but how do you think this risk score will hold up against other risk calculators that are available, given that it was specifically designed with vascular patients in mind?
Well, I think that we're seeing risk calculators related to specific diseases, and this falls in line with that. So there's a risk calculator for patients with aneurysms. There's a risk calculator, as I mentioned, the American College of Surgeons, which is more for general surgery. So I think that we're going to see increasingly risk calculators. But I also think that this should not change our idea of what the appropriate procedure is. This helps you assess the patient's risk, but not telling you what procedure to do. And I think we've known for many years that if you can do a below-knee amputation, it's better than doing an above-knee amputation as far as the long-term survival and mobility of the patient. So it's not saying do a different procedure. It's more saying be aware of the risks of doing the procedure. And I think it will help clinicians in advising patients.
One of the things that I found most interesting in this paper was that DNR status was very strongly correlated with outcomes and was their number one sort of risk in terms of calculating the score. Were you surprised by this at all?
Actually, I wasn't. I think that some people have used the term looking at an eyeball test as to how healthy or sick a patient is. When you're DNR, it tells you that patient has multiple comorbidities and a low likelihood. They're often not independent. They may have dementia. So DNR is a combination of many factors that make you think that it would be inappropriate to resuscitate a patient. We are seeing an increasing number of papers that talk about a frailty index, and there are different ways of calculating. But I think it's the same thing. It's whether you call it the eyeball test or a frailty assessment or DNR. To me, is just a proxy for these patients who have multiple comorbidities, and I don't think it's surprising that they do poorly.
One last question. So being a VA study, and the authors mentioned this as well, the study population consists predominantly of white males. Do you think it's safe to extrapolate from the study to other populations, or will external validity be a concern? And obviously, the authors mentioned themselves that they plan on validating this study with other cohorts.
Yeah, I think validation is critical because, as you pointed out, the VA is predominantly male, and women have been shown to have worse outcomes in many vascular diseases, possibly because they have smaller vessels, possibly because disease is diagnosed at a later date. So I don't think it's reasonable to assume that it's going to be identical. I think what you can assume is that it's probably in the same direction, but that it will need to be validated. And my assumption is that the information will still be useful, but it will be slightly different when you have a population which is of non-veterans who tend to come in with more advanced disease and more comorbidities when there are no women, that it's a very selected population. And so I think the authors comment that it needs to be validated with a non-VA group of patients is very appropriate.
All right, let's move on. The third paper is titled Endovascular Treatment of Spontaneous Renal Artery Dissection by Zhang et al. This is a case series of patients with spontaneous renal artery dissections treated with endovascular therapy at 2 hospitals in China from 2007 through 2018. Subjects were excluded if they had a history of trauma, aortic dissection, arterial catheterization, surgical clamping, or any vascular disease affecting this area, including atherosclerosis. So they were truly looking at spontaneous renal artery dissections only. There were 14 total subjects enrolled with 15 total dissected arteries. The technical success rate was good in this paper, with 14 out of 15 arteries undergoing successful stenting, and the one artery that was not successfully stented was in the patient with bilateral dissections. The authors report significant improvements in hypertension and renal function post-procedure, and on follow-up imaging at 3 and 6 months, all of the stents were patent, either by CTA or Doppler. So, Dr. Lawrence, with spontaneous renal artery dissection in the absence of trauma being as rare as it is, about 200 reported cases in the literature, how should we be treating this disease today?
Well, I think that the way that these authors treated it is appropriate, but I would be very careful about extrapolating from an Asian study to the world, primarily because often there are different manifestations and different diseases in Asian patients than there are non-Asian. I was involved several years ago in a spontaneous superior mesenteric artery dissection, which has a similar risk factors, and the largest number of patients submitted to our study in a multi-institutional study came actually from Japan. And from that, I learned that something that we think is quite rare for them was quite common. So whether or not this will extrapolate to the U.S. population is something I think we just need to watch. But their approach, I think, was reasonable. They had excellent outcomes. I did read some of the reviews by the editor and the reviewers, because this is not a paper that I personally selected. But I think that the questions are all of whether or not all these patients need to have stenting, or there's a subgroup that could be managed medically and controlling their hypertension and managing their pain, or whether all need to have stenting. Their outcomes were excellent, but there's no control as far as other alternatives for the management of these patients.
Right, and that sort of leads into my next question, which is, do you see any potential downsides to routinely treating these dissections with stents that may not have been mentioned in the study, or that may manifest themselves down the line?
Well, the reviewers of this paper, who, by the way, suggested it be published and were not overly critical, but wanted to know more about the technical details. How close to the branching of the renal arteries is appropriate for stenting? Is there a minimum size of a renal artery? Is the degree of narrowing or dissection an important factor. In other words, if the dissection results in a 50% stenosis, is that adequate for stenting? Because, as you know, all these patients were identified due to the sudden onset of flank pain, and many of them were middle-aged male smokers. And so it was a subgroup of a large population with flank pain that came into the emergency room. And the question is whether or not some of these patients could have been managed with medical therapy, with observation, and not required the stenting. The fortunate part of it is when they did their 3 and 6 month follow-up, that the restenosis rate was extremely low. In fact, I don't think there were any patients with restenosis. The control of blood pressure was good, and so the anatomic result and the functional result as far as blood pressure control looked great. The only question is, were they being overtreated, and were there any patients that did not need to have the stenting? But fortunately, their outcome was so good that I think at this point it's the appropriate way to manage these patients, unless someone can show that some subgroup of this group of patients can be managed with medical therapy and observation rather than stenting.
And it's obviously very difficult to identify those subgroups because with this disease being as rare as it is, at least in the United States, it's difficult to draw conclusions from just a handful of people. Our last paper is titled Upper Extremity Arterial Endovascular Interventions for Symptomatic Vascular Access-Induced Seal Syndrome by Chun and colleagues. This is a single-center retrospective analysis from 2006 to 2016 of patients with stage 3 or 4 vascular access-induced seal syndrome. Subjects were divided based on location of atherosclerotic disease, proximal or distal to the anastomosis, which in this case ended up being proximal to the elbow or distal to the elbow. Subjects underwent diagnostic angiography followed by stent placement for subclavian artery lesions and angioplasty for brachial and distal arterial lesions. 98 total patients were enrolled, 28 of whom had disease above and 70 of whom had disease below the anastomosis. Patients with disease below the elbow had significantly higher rates of tissue loss at baseline, 41 versus 16%. However, the technical success rate was the most differential thing between these groups. It was 100% for patients with disease above the elbow, and 91% of those patients had significant symptom relief at 30 days, with only 4 patients requiring proximalization. However, in the below elbow group, the technical success rate was much lower at 79%, and only 51% of patients had symptomatic relief at 30 days, and 80% of those who remained symptomatic required proximalization, whereas the remaining 20% required ligation of the access. So this group also had 11 digital amputations compared to none in the above elbow group, and other secondary outcomes were relatively similar. What were some of the findings that you found the most interesting in this paper?
Well, I found a very clear message that proximal disease does extremely well with endovascular, with stenting, or with angioplasty. And as you mentioned, the stenting for subclavian and angioplasty without stenting for brachial artery lesions. Below the elbow, in the more distal disease, as is the case with the lower extremity, does not do anywhere near as well, and in fact has a pretty high failure rate, whether it's measured by continued pain, amputation of the fingers, or closure of the restenosis. What I found a little surprising, and I don't think it matches many other clinicians who do a lot of vascular access, was that the authors divided into above the elbow and below the elbow. And I think many of us have found that patients often have disease both above and below. And I think that remains to be seen why their group had just above or below, rather than some of the patients having both above and below. But the message was clear that patients do well with endovascular approaches above the elbow, but poorly when they have a procedure below.
Naturally, some of the findings we see in this study are probably going to be from the fact that patients with disease below the elbow were kind of sicker at baseline, as manifested by the baseline difference in tissue loss, the 41 versus 16%. With that in mind, how should we use the results of this study to counsel patients or to inform our practice?
Well, the problem is, as you know, that it's not like you have an option of not doing the procedures. This isn't like claudication. These are patients who need access for dialysis. So I think that when you find patients who have evidence of disease prior to the procedure, you really need to look carefully at both upper extremities to make sure that you're picking the proper site for the procedure. So that, to me, is one clear message, was rather than correcting it after the procedure, the better option is to try to screen and identify lesions and disease and try to put in the access device or the access procedure in the arm with the least disease. And I think that is an important message. And then thinking in terms of different types of options, there may be some patients who actually may do better if they have very distal disease. They may actually do better with central access than as a more permanent solution than they would with distal disease that's likely to result in ischemia in the hand and either going to require procedures which are only 50% successful, or taking it down and ligating it after putting it in. So I think it's just telling us, look really carefully at the patient preoperatively, try to identify particularly distal disease below the elbow, and try to avoid doing an access procedure in that arm.
Thank you very much for that informative discussion. I just have one more question about this particular paper and these patients in general. Do you think the management of patients with more distal lesions will change in the future as we continue to improve our endovascular techniques and the stents that are available? Or even if, I know this is controversial, but if drug-coated balloons may be used for some of these more distal things? Or based on this study, should we be quicker to jump to open techniques or access ligation given the poor long-term outcomes?
I think at the present time, as you pointed out, that shifting a little bit more toward open techniques for the patients with forearm disease is a good is something that's good now. But as you've implied or stated, as in the devices to do angioplasty, stenting, and to prevent restenosis get better, I think that the results will get better, but it may not happen soon. And I think it will always be a challenging group of patients, far more challenging than the proximal large vessel disease. So things will get better, but they're never going to be comparable to more proximal subclavian and brachial disease, which can be treated with either balloon angioplasty or stenting. I don't think that the results are going to ever be comparable in the forearm to those proximal to the elbow crease.
Dr. Lawrence, thank you very much for joining us and for offering your perspective on these papers. And again, for our listeners, they will be available for the month of December on the JVS website free of charge.
Thanks, Jacob.